All right, so we're going to talk now about dysrhythmias, and cardiac dysrhythmias are not necessarily a disease on their own. They can occur without underlying disease, but they can also be a symptom. So you may have dysrhythmias in a structurally normal heart, or they may be associated with a congenital defect or with a cardiomyopathy or cardiac tumor. Sometimes it's just an abnormality in the electrical system. Some dysrhythmias are well tolerated, self-limiting, they go away on their own. Some decrease cardiac output, and some can cause sudden death. They are diagnosed with a recording cardiac monitor, a Holter. They might be diagnosed on a 12-lead EKG if the person is in that dysrhythmia at the time. But what frequently happens, patients have weird symptoms that indicate maybe they have a dysrhythmia. They go to the doctor, they're not having symptoms at that time, the EKG is normal. So a recording monitor, which also may be called a Holter monitor, records their EKG basically for several days. Typically, those are worn for 2 to 3 days, potentially up to, I think I've heard as long as a week, but most common you're going to hear about 3 days. They may also have a cardiac cath for electrophysiology. And remember the risk of cardiac cath, so they're not going to do this just because they think someone might have an arrhythmia. This is more, they really are narrowing it down and they're trying to figure out what's going on, and they have a real reason to suspect it. They also may be recorded with a transesophageal recording. Again, that's invasive, so this is not a first step. This is we really think something's going on. We're going to try to figure out what. They may be classified in different ways. They may be classified by origin, where they start in the heart, or by characteristics. So we're going to look at classifying by characteristics, basically. Bradydysrhythmias are heart rate that is slower than normal, okay? Sinus bradycardia is the heart is in sinus rhythm, it's just slower than normal. It's slower than the lower end of what's considered normal. It can be caused by autonomic dysfunction, or it can happen after surgical repair. One thing you need to know is that kids who are very athletic, actually adults who are very athletic, will have a lower resting heart rate. So if they have a lower heart rate, say in the 50s, and they're not symptomatic, that is likely to be, you want to ask, do you run? Are you an athlete? What sports do you play? Because that can be just a normal alteration based on having really good cardiovascular fitness. But if they're having a slow heart rate that's below the lower level of normal, that can be from either an autonomic dysfunction or surgical repair. Complete AV block, atrioventricular block, is when the electrical system that causes the atria and ventricles to contract is not communicating well. And so that's going to cause a very slow very slow heart rate. You're going to get a lot more in depth into these EKG specifics next year. I don't want you to stress too much about it. I want you to think about what's going to slow it down and what's going to speed it up. So a complete AV block is also usually going to cause a bradyarrhythmia. It's going to cause the heart to slow down because the contractions are not working together. This can be congenital. It can happen after surgery. It can be self-limited, especially after surgery if there's some swelling, and once the swelling goes down, it gets better. Temporary pacing may be needed. So if they have a bradydysrhythmia, their heart is beating too slowly and they can't maintain a high enough heart rate for good cardiac output, they may need a pacemaker, okay? That can be temporary if it's due to edema or inflammation, or it can be permanent if it's a problem that doesn't go away. Tachydysrhythmias are faster than normal. Sinus tachycardia, again, normal sinus rhythm, but so the tracing is normal, but it's faster than it should be. So what causes sinus tachycardia? It's really common. Fever, anxiety, pain, anemia, because we're trying to get that blood that doesn't have enough oxygen in it circulated better, dehydration. Usually it's self-limited. Most of the time, sinus tachycardia is self-limited. Once the cause is corrected, it corrects itself. Supraventricular tachycardia is a really rapid heart rate. It is a regular heart rate, usually 200 to 300 beats per minute, caused by rapid stimulation of the atria. It doesn't allow for adequate filling of the heart chambers. The onset is sudden, and then they can convert back to sinus rhythm just as suddenly. In young children, what might this look like? Poor feeding, irritability, pallor. Older children may tell you that they may have palpitations. They may tell you that their heart feels funny. Dizziness, chest pain, diaphoresis. Okay. If it's sustained, if they stay in SVT for very long, they can have symptoms of heart failure. Management depends on severity, and if one step doesn't work, the next one is tried. The first step is to try vagal response. So ice to the face, massaging the carotid arteries, having an older child Valsalva. So have them like take a breath and hold it, can sometimes get them out of it. Younger kids may convert due to crying. So when they cry, they have that scream, 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 big breath, hold their breath, scream, scream, scream. That can actually convert them. The next step might be adenosine. And adenosine is like a cold boot for your computer. Okay, it's a cold boot for your heart. Adenosine actually temporarily stops the heart, and then it starts back usually in a better rhythm. It doesn't feel good, by the way. I've been told by people that have had it when they're awake that it feels like you've been kicked in the chest. Adenosine actually metabolizes very rapidly, so it has to be given with a really specific setup. It's pushed really rapidly, followed by a really rapid normal saline flush to get it in quickly enough so that it will work before it's metabolized. If it works, you get a brief flat line and then a return, hopefully, to normal sinus rhythm. Pacing or cardioversion may be done. Usually that's, or they're going to require sedation for that. Long-term management, if they keep going back into SVT, then they may use digoxin, which slows the heart rate. Propranolol is a beta blocker, slows the heart rate. Amiodarone. Ablation is a procedure for someone who has chronic or just recurrent. Usually don't stay in SVT all the time, they'd be in heart failure, but people who have recurrent SVT, so like a chronic recurrent issue, they may, if they can find the location in the heart that's triggering the abnormal beats, they can actually damage that part of the heart so that it doesn't, so that part of the system, so that it doesn't do that anymore. Okay, so they would use radio frequency to do that, or cryo ablation. So they just like freeze out that little bit. It's a long procedure. It's done by cardiac cath, and so we do the prep and the care for pre and post cardiac cath for that. So we've talked about bradydysrhythmias, tachydysrhythmias, conduction disturbances are the other, and there are multiple abnormal heart rhythms. So what you need to know for this test about dysrhythmias, because next year you get a lot more in-depth information about it. What you need to know, if the heart rate's too slow, what can happen, what can cause it, what can happen because of it. If it's too slow, we're not getting blood to the body, right? And what's done about it. If it's too fast, what causes it? What can happen? If it's too fast to fill, then we're not getting blood to the body, right? And what can be done about it. All right. Nursing care, you need to be able to recognize an abnormal heartbeat on assessment. So when you're listening, is it too fast? Is it too slow? Does it sound irregular? All infants, you need to do an apical pulse for a full minute. If a dysrhythmia is suspected, you're assessing this child and you think they may have a dysrhythmia, you need to do an apical and radial pulse at the same time to see if every beat you hear at the heart gets through to the peripheral circulation, and put them on a cardiac monitor. And then we would be educating about the procedures they might have, medications they might take, and how to recognize symptoms. Okay, in the next section, we're going to talk about cholesterol and blood pressure.